So, good evening to one and all. Today, we are going to discuss some of the basics about stroke. Stroke is a little bit uh, confusing topic when it comes to management because a lot of new developments have come in. So, comparing to when I first started learning about stroke in my final year of MBBS, now a lot of things have changed actually with regards to stroke management. So, it's good to actually review what the guidelines are right now, as well as re-emphasizing the basic goals of good stroke management. So first we'll start with the definition. What is a stroke? So stroke is basically any acute focal neurological deficit that can be attributed to a vascular cause. So the important thing here is acute. So if it's like a very gradual onset or occurring over weeks to months, then your differential starts to vary. So that is a basic funda of neurological evaluation. So initially we localize where is the lesion, then we'll try to figure out what is the lesion. So usually stroke has to be somewhat acute. So some of you might have learned this definition, like signs and symptoms will last more than 24 hours. That is a completely outdated thing. So if your faculty are still teaching you that, then I think you should actually refer to some of the newer sources because lots of things have changed since that definition was used.
भाई वंगी पे नहीं होते हैं कट्टे हुए
So I would request people to please mute themselves. So unless you're trying to ask any doubt. So coming to classification of stroke. So basically, what we classify strokes into two. We have ischemic strokes and we have hemorrhagic strokes. Which one is more common? Ischemic strokes are more common, so around 85% as per our textbooks are ischemic strokes. Hemorrhagic strokes are like 15%, but unfortunately, hemorrhagic strokes are generally far worse when it comes to mortality and morbidity. Ischemic strokes are again classified into thrombotic strokes and embolic strokes. Which one is more common? Embolic strokes are more common. So that might be a little contrary to what you might be expecting, but embolic strokes are like 75% of the ischemic strokes, and thrombotic are more like 25% of them. So, so we have three big categories. You have thrombotic strokes, we have embolic strokes, and we have hemorrhagic strokes. So, what are the differences with each of these types of strokes? Because thrombotic strokes is usually caused due to a thrombus formation at the site of the vessel. For example, you have an atherosclerotic plaque which is developing over several years. Finally, that plaque ruptures. It ruptures to release thrombogenic material. That results in the formation of an acute clot that actually blocks off the entire vessel. That results in a thrombotic stroke. Embolic stroke is where you have emboli that is coming from a distant source, somewhere outside the brain, like in the carotid artery, like from the heart. It goes up into the brain, blocks the arteries, that results in a stroke. So that is embolic. Hemorrhagic stroke is basically when an artery is rupturing, like a berry aneurysm rupturing. Predisposing factor, thrombotic, any kind of vascular risk factor, diabetes, hypertension, hyperlipidemia, whatever, like it's the risk factor for the thrombotic stroke. Embolic, basically, if you have a source of clot somewhere, like in the heart, like the patient is having mitral stenosis, some clot formation in the left atrial appendage that can lead to stroke, that can go up, disseminate up, or the patient is having atrial fibrillation. Once again, the atrial fibrillation predisposes to clot formation. In hemorrhagic stroke, it can obviously be due to some kind of trauma. Otherwise, it can be bigger risk factor. There is usually hypertension. So coming to onset, thrombotic stroke generally can be little bit more gradual onset compared to the other two. Embolic and hemorrhagic generally tend to be more acute strokes. And coming to neurological deficit, again, thrombotic generally has a gradually progressive deficit. Embolic usually has the maximum deficit as is at the onset itself, then it recovers, then it again comes. Sometimes this can be a very dramatic. Suppose patient is having a source of embolus in the heart, and it's keeping on giving out emboli again and again.
रेशमा सुना दीदी
So you can have multiple strokes in a very coming
What's
one
that?
after the other in a very uh, with a very little gap in between. So that is typical of embolic. And hemorrhagic is usually rapid onset and acute onset and rapidly progressive. Timing usually embolic classically occurs in sleep, so your wake up strokes generally tend to be thrombotic stroke. Emboli and hemorrhagic strokes tend to be occurring at the height of activity. Headaches are more common with hemorrhagic stroke. Seizures most maximum with embolic can be occurring with hemorrhagic also. LOC most commonly with hemorrhagic strokes, and recovery again usually the mortality morbidity is going to be very much worse with the hemorrhagic stroke. So the funda that I would like to give you at the end after going through all of this is that hemorrhagic strokes tend to present with more headaches, more sorts of altered sensorium, a lot of seizures, maybe some vomiting, but and this is clearly written in Harrison, you cannot distinguish between hemorrhagic stroke and ischemic stroke on the basis of clinical features. You should not do that. You have to get imaging. You are not supposed to start some specific therapy without imaging findings. So, stroke can be further subclassified by something called the TOES classification. Basically, can have large vessel occlusion, large artery atherosclerosis. You can have occlusion of very small vessels. We come to the anatomy of the blood vessel in a little bit. Those are called lacular strokes. You can have cardioembolic strokes originating from the heart, or you can have strokes of some other etiology. And sometimes you, despite extensive evaluation, you are not able to actually find out the etiology of the stroke. So that can also happen. So the cause of stroke can vary based on geography. For example, carotid artery atherosclerosis, very common in USA. Moyamoya disease, very common, but not very, but more common in Japan. Mediterranean areas, sickle cell becomes more common. In India, intracranial atherosclerotic disease is more common among these. So there can be a lot of geographical variation. There can be a lot of variation within India also. So you have to keep that in mind. So no stroke lecture is ever going to become complete without some kind of discussion on neuroanatomy and blood supply, unfortunately. So please forgive me about this. So we'll just briefly try to review the blood supply of the brain. You basically have an anterior circulation and you have a posterior circulation. So you'll go from below up. So starting from the arch of aorta, we are the three branches: brachiocephalic trunk, left common carotid, left subclavian. Brachiocephalic trunk divides into the right subclavian and right common carotid. And from the first part of your subclavian artery, what do you get? You get your vertebral arteries. Vertebral arteries go up in the neck. You go foramen transversarum, C2 to C6, the binds around the C1, and then basically forms your basilar artery, goes along the pons, and then somewhere around the midbrain, it will divide into the two posterior cerebral arteries. So this is basically the posterior circulation. And the posterior cerebral artery will communicate with your anterior circulation through your posterior communicating artery. So that is the posterior communicating artery. Then you have an anterior circulation as well. Anterior circulation is basically starting with your common carotid. Common carotid will in the neck, it will divide into your external carotid and your internal carotid. How can you differentiate between your external carotid and your internal carotid in terms of imaging? External carotids will have branches in the neck. Internal carotid will not have branches before it enters into the cranial cavity. So that is how you differentiate on imaging between external and internal carotids. And once it goes into the brain, eventually it will divide into your. Actually, you can actually say that it trifurcates into three things. One is your ACA, one is your MCA, and one is your PC, the posterior community. You can say that also. But But basically, the big important branches are going to be your ACA and your MCA. I hope that made some sense. We'll review a little bit more. Here you can see a very good image of your common carotid here, and you can very well differentiate that your external carotid artery is having a lot of branches here, but your internal carotid artery is not going to have any branches until it goes into your cranial cavity. There it will eventually divide into your MCA, which will go laterally, and your ACA, which goes medially. Again, another look at your the posterior circulation here. You can see that your vertebral artery is coming out of the first part of your subclavian, going up C60 to C2 for foramen transversarium, then goes winds around the C1 and eventually forms your basilar artery. Again, here you can see the circle of Willis here as well. You can see there your vertebral arteries, basically they will give a branch downwards as well, which combine to form your anterior spinal artery. Vertebral arteries will also give a important branch, which is called your posterior inferior cerebellar artery, which is your pica. And pica can occlusion can result in your Waardenburg syndrome, if you might recall from MBBS. Little bit up, it will go from your it will form your what? Basilar artery. Basilar artery, one important branch is lower down, is going to be your ICA. ICA will give another branch that is your labyrinthine artery. So sometimes if you have an ICA stroke, it may be associated with hearing loss. Usually strokes don't present with hearing loss, but in these kind of posterior circulation stroke, rarely it can present with hearing loss. That is why in your HINTS plus exam, you check for hearing loss. If for those of you that actually attended the vertigo lectures that we had a few months back. Then a little bit up, we have your pontine branches here in of the basilar and the pons, and a little bit up you have your superior cerebellar artery as well. So you have two inferior cerebellar arteries, that your anterior and posterior. Then you have a superior cerebellar artery as well, before it eventually gives your PCAs. So I hope I haven't lost anybody here. So again, adding a little bit more detail to the circle of Willis here, you have your PCAs, and you have posterior communicating artery. The part proximal to the posterior communicating artery is your P1 part of your PCA, and the part distal to that is going to be your P2 part. So similarly, for your ACA, you can also have an A1 as well as an A2 part based on your position of your anterior communicating. Your MCA branches are a little bit more complicated. I will come to that. Your MCA, you have your ICA, then you have your horizontal part here, which is called your M1 part of your MCA. Why is this important? You give your lentricular striate branches from your M1 segment. Why is that important? I'll just tell you in a little bit. Then it goes into the Sylvian fissure as your M2 segment. Then you have another part which is your M3 segment. Then outside this cortex is actually your M4 segment. So you have M1, M2, M3, and M4. So when it comes to thrombectomy, which is the important part, your ICA and your M1. So whether to include M2 or not based on the size of the M2, that becomes a little bit complicated. I'm not going into that in this particular lecture. But basically, what do you mean by large vessel occlusions? Think about ICAs and M1. Okay. So this is a very important part of the brain, and that is why I'm stressing. It's not possible for me to go through the entirety of your neuroanatomy in one lecture, but I just wanted to stress upon the key parts that about stroke. So these structures are very important. When you're looking at your CT, this particular section is your key section when you're looking for stroke evaluation. So we have what your basal ganglia, basically. So you have your and your related structures. You have head of the caudate nucleus. Laterally, you have the lenticular nucleus. Medially, you have a thalamus. In between these structures, you have a boomerang shaped thing that is your internal capsule. And in the posterior limb of the internal capsule, what do you have? You have your cortical spinal tract. Okay, so here is how it looks on an cadaveric section. So you can see these are basically subcortical gray matter. Gray matter. You have your caudate nucleus, thalamus, and your this thing basal lentiform nucleus, and in between you have your internal capsule. So, and lateral to the lentiform nucleus, you can have your insular cortex, and you look at the shape of this insular cortex. This is actually very, very important. If it's smooth, the contours of this insular cortex is lost, that is a very important early signs of stroke on the CT, on plain CT. I mean. Similarly, you can have things like disappearing basal ganglia as a sign. So, if the basal ganglia is no longer clearly delineated on the non-contact stand, that is again something that could suggest that the patient is having a acute infarct. So this particular section is the key section that I want people to remember when it comes to stroke evaluation. So again, going back to the M1 segment, you see this lenticular striate arteries. So these are very, very small arteries, but they are supplying a very, very important area of the brain. They're supplying your basal ganglia and your internal capsule. So even if you have a very, very small thrombus in your these very, very small arteries, so it can result in very, very devastating strokes, complete gross hemiplegia one side. So that can happen. So that is why these lacunar stroke are a big problem. So and another clinical point that I'd like to tell you is that the problem with these large vessel occlusion is that they tend to not respond that well to your thrombolysis. Thrombolysis, that doesn't mean that you shouldn't give thrombolysis, but the response to thrombolysis is very less. Like maybe 15 to 20% of the cases will actually have a good response to thrombolysis. That is why the whole concept of mechanical thrombectomy has come into such popularity in the past two decades. So a little bit about dominance, because this is clinically important. So which cerebral hemisphere is dominant? Usually left side. Most people are right-handed. 90% of right-handers have left side of the brain will be dominant. Even in left-handers, most of the time, more than half of the time, they will still be having left side of the brain dominant. Why do I want you to know this? Because right-sided strokes will usually involve the left side of the brain, and left side of the brain controls your speech. So obviously, any stroke that will affect the patient's ability to speak is going to be a very, very devastating stroke. So all make this correlation in your mind. Right-sided strokes, always think about speech problems. So again, dominant hemisphere looks at speech, and also you can have other problems like calculation, reading, etc. Blah 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 blah. I'm not going into Gerstmann syndrome and all in this particular lecture, so we don't have to worry about that. Non-dominant hemisphere, so more important for spatial orientation, you can have things like hemi-neglect with non-dominant hemisphere strokes. So I'm not going into deep about all of the various areas, but just remember that your precentral is your precentral iris is your motor area, and the postcentral is your central area. So you can rest easy because that is the entire neuroanatomy that I'm going to tell you in this particular lecture. So you can rest assured that the worst is over. So from now on, we're going to speak things that are going to be a little bit more easy to digest. So coming to stroke management, this is extremely important. Every single person should know this inside out, whether it be MBBS, whether it be PG, DM, whatever it is. You have to know all of these things. First thing, time targets. There are certain time targets that we have to follow to make sure that we are providing good quality care to the stroke patient that present to our hospital. So what are that? What are they? Whenever you suspect stroke, you have to immediately activate the stroke team or call neurology, whatever the protocol is at your hospital. You have to activate that immediately. Patient should be sent to the CT scan room within 20 minutes. CT report should be available within 45 minutes. And if the patient is eligible for thrombolysis should be started within 60 minutes. So immediate 20 minutes, 45 minutes, 60 minutes. Remember this. Practically, this is important. This is to judge yourself and your hospital whether we are giving good quality stroke care or not. And if you're not, perhaps you have to make some changes at an administrative level. So what is the easiest way to spot a stroke? So this is actually for even people who are not actually doctors to spot a stroke, and this is actually initially made in USA for pre-hospital care. So it is called FAST. FAST includes basically facial droop, arm drift, basically ask the patient to hold both hands out, and if one hand is going down like this, that is suggestive of a stroke. And speech, if there's any slurring of speech. But the problem of this fast is that it can miss posterior circulation stroke, because posterior circulation stroke generally don't may not present with these kind of things. That is why something else that has been created called B fast. B fast, there is included two more things. One is balance issues. Can the patient walk normally? Make the patient walk. See how they're walking. Are they walking normally? If they're not walking normally, that could be a stroke if it is acute onset. Vision changes. So if the patient is having any acute onset vision loss, any field defects, so that could be a stroke. So B fast has been, so the fast thing has been expanded to B fast. So this is not for doctors. This is even for lay people to spot a stroke and call an ambulance and get to the hospital right away. As a doctor, you will have to do a very quick history and very quick examination to find any focal neurological deficit. Always make sure to look at the face, see how the patient talks, look for any facial asymmetry, and look for any grossly look for any motor weakness or any gait issues. And if present, immediately activate the stroke team in your hospital. The worst thing that could possibly happen if a possible stroke patient is kept in the queue in the line. So that should never happen. Stroke patient should be fast tracked into the ED always. So now we are talking about something called stroke mimics. What do you mean by mimic? Something that looks like a stroke, but it's not actually a stroke. So there is a mnemonic called MEDICS, which can help you to remember the all of the things that may mimic a stroke. So the CMC Vellore did a study a few years ago, where they found that maybe around 20% of all the stroke suspects that they that presented to them actually had a stroke mimic. So these things are important to know actually. So which of these are the most important from a clinical point of view? Number one, hypoglycemia. Always try to rule that out in any stroke patient. Post-ictal, which is actually the most common cause in that particular study. Post-ictal paralysis, that is called towards paralysis. Very, very difficult to actually differentiate that from a stroke. Then migraine, particularly some particular variants of migraine called hemiplegic migraine. Again, extremely difficult to actually differentiate from a stroke, because but you can have like some clues from the history that the patient is having a history of migraine now and headache now coming with the and generally a young patient coming with the focal weakness. So you try to keep that thing in mind. So and you can also have other things like trauma. So a lot of that can also be confusing. A lot of strong patient fell, then became altered. You're not sure if it's due to trauma or due to a stroke. So that can also be a little bit tricky from time to time. So these are the very key things that I would like to remember when it comes to stroke mimics. What do you mean by stroke chameleons then? So we'll ask somebody. Okay, Salik, what do you mean by stroke chameleons?
I don't know, sir.
Okay, no issue. So stroke chameleons basically means it is a stroke, but it is presenting in a very unusual manner. For example, patient is having LMN facial palsy. LMN facial palsy presents to you what do you usually think? Bell's palsy hoga. And you'll give the patient antivirals and maybe antivirals and some steroids and send them home. But patient that was actually due to a stroke in the pons, which resulted in an LMN facial palsy. So that is a stroke chameleon. So that is a stroke that actually presented that in a very unusual manner. That's something that we usually don't think of as a stroke. Or a patient coming with confusion or agitated behavior could be due to bilateral occipital stroke. So that because the patient's vision becomes affected, then patient becomes agitated because of that. So those can be very very weird ways of strokes presenting. And the problem here is that most of the time these stroke chameleons are very 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 difficult to spot on our usual NCT head. So a lot of them generally need higher imaging like your MRI. So big. What is the most important test that you have to do when a patient comes, you are suspecting stroke in a patient?
Sir, first we'll send a blood glucose to rule out stroke mimic.
Very good, very good. The most important thing is RBS. Hypoglycemia can cause focal neurological deficit. More commonly, it causes right-sided weakness compared to left-sided weakness, but it can definitely cause some focal weakness, and generally it will resolve with glucose correction. So the only test that you actually need to do before getting sending the patient to CT is RBS. You don't need to wait for any other investigation before sending the patient to CT. We in our area, we generally will get an IV line in for the patient, because generally for our stroke protocol, we'll do a CT head followed by a CT angio in one setting to avoid sending the patient back and forth at multiple times. So that is something that we do in our center, and we generally do that very quickly. So it is always a priority for us whenever a stroke patient comes. It's not like we're putting a cannula in Aramse and taking all the samples. So, but the only test that is a must when before sending the patient for CT is your RBS. After that, you obviously go for your imaging. So, what are the goals of imaging? So, number one, exclude hemorrhages. And then that is the first and foremost thing. And that was the only thing that I learned when I was in MBBS. But the scope has changed in the last 10, 15 years or so. So from the time when I was in final year MBBS. So now the goals also include trying to find out whether there is any large vessel occlusions, trying to find out exactly what is the volume of the core and what is the volume of the penumbra. So again, we'll ask Yadu, what do you mean by umbra, and what do you mean by penumbra?
I think it's the area in and around the stroke. I don't know exactly, sir.
Okay, so basically, when an artery is occluded, so the initial there is certain area that is completely dead, so completely necrosed. There's nothing you can do for that. Your treatment is not going to improve the blood flow to that area. So that is your umbra. That is this in picture. You can see the black here. That is dead tissue. Surrounding that you have area that is actually not dead, but it is like dying. So that is an area where intervention which will actually be beneficial. We can actually prevent damage to that area, and we can prevent the progression of the neurological deficits in that particular patient by saving that amount of tissue. So our imaging the stroke has evolved so that we are now actually trying to figure out exactly what is the core or the umbra area and what is the penumbra area. So there are some terminologies that are used to describe some of the signs with CT head, and a lot of this is variable. So in general, the hyperacute is reserved for finding within 24 hours. It is again divided into early hyperacute and late hyperacute. Early hyperacute is like within 6 hours. Late hyperacute is 60 to 24 hours. Acute is defined up to 1 week. As far as radiology goes, subacute can be defined as 1 to 3 weeks, and chronic as more than 3 weeks. This is what is given in Radiopedia, but certain societies have given as 6 months. So subacute is up to 6 months and more than 6 months, which is kind of absurd, to be honest. But that is how some people define it. So there's a lot of different. There's a lot of variation with regards to this terminology. But what are the clutch points? NCD can be normal in ischemic strokes. Number one thing is, again, always rule out hemorrhage. That is the first and foremost thing. All the other things are like extra things that we do for ischemic strokes. So one of the earliest things that you can get on a CT in ischemic stroke is something called your dense MCSI. So when you have a thrombus inside the a vessel in the brain, it can here appear a little bit hyperdense. You can compare the left-sided MC here compared to the right side. It is more hyperdense. This is the dense MCSI. It is a sign of an acute infarct. Other things that you could signs of a hyperacute infarct includes loss of your normal insular ribbon sign and loss of the gray white differentiation or disappearing basal ganglia. So these are the other signs that you can look for in the hyperacute phase. So we'll ask Salik. So do you see any abnormality in the scan? Okay, there is an abnormality. This is a stroke lecture, so there is an abnormality, but where is it?
There is some the anterior right side. There is some hyperintensity.
Yes, so we generally use terminology like density, not intensity. Intensity is a term that we reserve for MRI. Density is something we use for CTs. But you can compare with the left side. Look at the insular region here. Look at how smooth it is, and compare with the left side. The differentiation of this particular area is completely gone compared to the left side. So this definitely looks like an acute infarct. And if you compare it with your CT angio, you can clearly see that there's no flow here beyond this. So this is a proximal M1 occlusion of the right side. So if people are confused about right side, left side, we had a lecture by Jyoti Sarup sir a few weeks back about how to read basics of NCCT head and all. So you can go see that video later on if you're confused about the basics. So Sahana, do you see any abnormality here?
Sir, on the right side, we can't see the ventricle properly. There is loss of gray-white differences.
I think that is actually because patient is not actually symmetrical.
Okay.
So it's okay. So you cannot actually spot anything immediately if you're looking, especially if you're non-radiologist. But there is some edema, the loss of the normal contour in the left frontal area, which is actually extremely difficult to spot. The only reason that anybody would say that it is there is because this is a stroke lecture. Even though it's nothing, you're not able to see anything on the CT, you can clearly see the infarct on your MRI. So what is the best MRI for an acute infarct? Diffusion weighted imaging. So diffusion weighted MRI, that's the best thing for acute strokes. So you can clearly see it on MRI. Even within 1 hour, you can see the findings on the MRI. Obviously, there's practical problems with doing an MRI in India because it's not all going to be available everywhere. Not everywhere is going to be like AIMS where we generally can get acute MRIs done fairly easily in our center, which is not always, which is really not the case in more than 95% of the hospitals in India. There's something called aspect score. Where do we use it? MCA infarcts. You have to look for this at 2 levels. One at the basal ganglia level. This is again the level that I told you about when I was discussing anatomy again. This is the basal ganglia level. You can see the caudate nucleus, lentiform nucleus, indial capsule, everything here at this particular level. You have 3 things here: M1, M2, M3. They've divided the MCA regions into 3 here, and you have a level above this, like the we call it the supraganglionic level or the coronary radiate level. You have your M4, M5, M6. So how do you calculate an aspect score? Maximum score is 10. If one area is involved, you minus 1 from 10. So you get 9. If 3 areas are involved, you minus 3 from 10. You get 7. I hope this is clear. So this is useful where? For MCA infarct. Aspect score is used for what? MCA infarct. The utility of aspect score in a little bit because this has some implication for management. That is why I'm mentioning it here. So again, to NCT head, first and foremost, always rule out hemorrhage. Then you will see is we have ruled out hemorrhage. So then we will see is more than 1/3 of the entire MC area, not just your aspect, your entire MC area, more than 1/3 is involved, infarcted. In that case, you will avoid thrombolysis because this is what you call a malignant MC infarct. I mean, malignant MC infarct, you generally like to avoid thrombolysis because they tend to have poorer outcomes. Similarly, this can be correlated with your aspect score as well. If your aspect score is less than 7, less or equal to 7, generally we like to avoid thrombolysis. Around 8 to 10 is like a good range for actually trying out thrombolysis. So, if you have a normal CT or you have an MC infarct, but it's actually less than that, then you look for timing. If it's less than 4.5 hours, you thrombolyze. If it's more than 4.5 hours, then we try to go for further evaluation. We'll go for what that means. Further evaluation means we have to start looking for large vessel occlusions. So large vessel occlusions can be seen with your CT angio or MR angio. Generally, we are going to go for CT angio. That's going to be more easily available. In anterior circulation, you look for 3 6s. Onset less than 6 hours. NIHSS more than 6. We'll come to what NIHSS means in a little bit. And an aspect score more than 6. Remember these 3 6s, less than 6 hours, aspect more than 6, and NIHSS more than 6. So that is when you go for mechanical thrombectomy. If it is 6 to 24 hours, you can still do thrombectomy. So the window period for thrombectomy is 24 hours, whereas the window period for the thrombolysis was 4.5 hours. So generally, we were even that 4.5 hours is like it is changing. The concept is that 4.5 hours is also changing, but the window period for stroke is no longer 4.5. The magic number is no longer 4.5 hours. It is 24 hours. Keep that in my mind. Very important thing to know when you're, especially in triage, when you're receiving patients. Posterior circulation, large vessel occlusions, thrombolysis, thrombectomy, the evidence is not that clear. So the practice may vary. So maybe Sahana is going to speak something about that later on. So aspects for, again, as I told you, can be generally start from 10 and you start minusing from that. And the higher the score, the better is the prognosis. And again, 8 to 10, thrombolysis can be beneficial. 7 or less, thrombolysis is probably best avoided. So as you progress further on, then you actually can see very well demarcated infarcts on your NCT head. Like here, you can see in the left-sided basal ganglia, you can clearly see hypodensity, very clearly defined hypodensities. These are lacunar infarcts on your in your left basal ganglia. So we have discussed approach to NCT head, how to approach larger vessel occlusions, and how to basic approach how to mechanical thrombectomy. What about a wake-up stroke? So this for onset 4.4 hour, 6 hours, how do you actually calculate? So suppose your patient woke up around, was lastly normal when they went to bed around 11 p.m. The children of the patient noticed that their father was having a focal deficit in the morning at 6 a.m. So big. When they presented to the hospital at 8 a.m. So do you take the onset as 2 hours or do you take it as something else? Okay, I think Sobik is gone, so we'll ask somebody else. So Yedu, what
I don't know, sir.
Okay, so basically you will take the last known well time. So in these kind of wake up strokes, generally we'll take the on. At least this was the concept when I was studying stroke back when I was in MBBS. You took the last well time, when the patient was last 10 months. So that you take the onset from 11 p.m. Okay. Now the concept has changed because our imaging has gotten better in the last 15 years or so. So we can do other things to decide, is this patient who had a wake up stroke? Wake up stroke means that people notice the stroke only in the morning on getting up. Is it really less than more than 4.5 hours, or is it actually less than 4.5 hours? What kind of imaging can we actually do to figure that out? There are a couple of things that we can try. One is something called fusion flare mismatch. So MRI sequencing. So obviously you need to do MRI for this. So one of the indications for doing an acute MRI in a suspected stroke is wake up stroke. So when in diffusion weighted imaging, if you're seeing an infarct in the image above, you can see an infarct on the diffusion weighting imaging. But if you look at the flare sequence, you are not actually seeing an infarct. So what does this mean? This is likely an acute infarct. This is likely an acute infarct within 4.5 hours and may benefit from thrombolysis. Am I making myself clear? If I'm not if any of this is seeming confusing or something is not clear, please feel free to type in the chat box or speak in between. So it's fine. So you want me to repeat what actually, sir? So in the second
So
image,
the flare DWMRI part, sir. Flare and
so
DW.
patient is coming with a wake up stroke. We are not actually sure when the actual onset of the stroke was, whether it was less than 4.5 hours or more than 4.45 hours. So you do acute MRI. So this is one of the acute indication for acute MRI in the ED for stroke. So you look at the diffusion weighted imaging, you see an infarct. And you look at the flare images. If you're not seeing an infarct in the flare, you will see in the diffusion weighting and imaging, that is the best thing for stroke. That will give you this infarct earliest. The other sequences take time. So if you're seeing it on diffusion weighted imaging, but not seeing it on flare, it means that it is an acute infarct, likely less than 4.5 hours, and it is good benefit from thrombolysis. So this is why I said that the whole concept of the 4.5 hour cutoff in stroke is actually changing. Second image, the one below, here you can see a infarct on DWI, and you can also see an infarct on flare also. So this is likely more than 4.5 hours and probably less likely to benefit from thrombolysis. Clear?
Sir, excuse me, sir.
Huh.
So flare will show the infarct at or around 4.5 hours. Is that what this means?
So
So we
I
can
don't.
just- we
I'm
can
not
just
actually
do a flare, no?
recalling exactly the exact timeline, but it will give you a rough estimate. Less than 4.5 hours, more than 4.5 hours.
So we can just do a flare then, no? If it shows no infarct, and that means it's less than 4.5.
The thing is that you might want to actually look for the other causes as well. So it's sometimes you think it's stroke and you end up being something else also. So generally, it's not like we only do flare.
Mm-hmm.
And the best thing for a stroke is always going to be DWI. If you ask me, the one sequence that I would like for a stroke or a TIA is going to be DWA. It's not flare. Okay, so that is one thing.
Sir, are we supposed to mention in the MRI form, like we are supposed to write DWMRI flare sequences, please? So if we are
Practically
suspecting a
speaking,
wake-up
for
stroke.
our institute, so this is not going to be applicable elsewhere, but we are not actually authorized to order MRIs. So we have to do it in conjunction with the neuro team. So if we have to, our sign will not go basically. So it has to be signed by a neuro SR. So even if you want an MRI, you have to discuss with them and make them sign the form basically. Next thing is that you can try is go for perfusion imaging. where you can actually find out the umbra and the penumbra. So you can actually figure out the umbra and the penumbra, and you can see the mismatch here. You can see the in the lower image. You can see the umbra is small, but the penumbra is quite large. So this patient might actually benefit from some kind of intervention. So I'm not actually going into detail of how to go for CT perfusion, how to read it. So there are a lot of terms like cerebral blood volume, cerebral blood flow, mean transit time, lot of things. How to differentiate between core and penumbra. A lot of things. I'm not going into that because this is meant to be an introductory lecture. It's not meant to go into the deep into the imaging part. But just know that this is one of the advanced ways where we can actually look for mismatch between the umbra and the penumbra. How to assess for severity of the score? There is something called NIHSS, National Institute of Health Stroke Severity Scale. So there are 11 components. I'm not going to tell you how to actually do the score. There are online resources available which you can refer to learn how to actually do this particular scoring. Please don't try to do the scale as soon as the patient arrives. As soon as the patient arrives, you do the general things. RBS, active stroke protocol, immediately shift the patient for CT. So NIHS can actually be done at the CT room, not in the ED. So I hope that it is clear. So even if you don't know the whole component, at least try to remember the numbers like what is a minor stroke, 1 to 4 is minor, 5 to 15 is moderate, 16 to 20 is like moderate to severe, and more than 21 is like a very severe stroke. So it is goes from 0 to 42. So this is going to be difficult to remember if you're not heard this before, which is okay. So just try. So next time you actually see someone writing the NIHS score on a case sheet, just at that particular time refer this table, and then you will actually start remembering it better. So that is all about imaging. Now we are coming to the most important part of this lecture, that is general management of a stroke case. So initial management, always ABCD. Before CT, always ABCD. If the patient airway is threatened, we're always going to be intubating the patient before sending for CT. Never send in unstable patients to CT because death begins in the CT room. So always keep that in mind. Supplemental O2 only needed if the patient is actually hypoxic, otherwise not needed. In any stroke patient, maintain normothermia because fluctuation in temperature not good for the brain. Maintain AHA tells you to maintain a normal-ish glucose level like 140 to 180 because hypoglycemia is obviously bad for the brain. Very severe hyperglycemia is also going to be bad for the brain. So we'll try to optimize that as far as possible. Generally, the AHA recommends keeping it around 140 to 180. Don't try to go target something less than this. You will land the patient in hypoglycemia. BP control, what to do? I'll tell you in a little bit. Very important. Always, any stroke patient screen for dysphagia. Try to screen for dysphagia. See how they're actually swallowing fluids and all. If you think that they're not able to swallow things properly, make them NPU, put a Riles tube. Because very important thing, most patients with an ischemic stroke will not actually die of the ischemic stroke. But if the patient aspirates and lands up in aspiration pneumonia, that can result in death. So this is a very, very important and often forgotten part about stroke management. DVT prophylaxis is kind of controversial. Anticoagulant, it's like plus or minus, but they recommend like pneumatic compression intermittently to prevent DVT. And you have to watch for other things like complications like cerebral edema, seizures, etc. For example, if you have a big stroke, malignant MC infarct, the cerebral edema will progress at day 2, day 3, and that is the time where you might have to go for craniectomy, hemicraniectomy to relieve the pressure on the brain. Coming to a very, very important thing, BP control in stroke. Generally, for any neurological disorder, don't try to reduce BP too fast. Because reducing BP too fast may reduce the blood flow to the penumbra, resulting in more damage to the penumbra. So we do not like to reduce it too fast. So what are the cutoffs? cutoffs will depend on whether you are planning for thrombolysis or not. If you are planning for thrombolysis, you have to keep it at least less than 180 by 110. If you are not planning for thrombolysis, you can go up to 220 by 120. That is a significant amount. So don't think that 200 and 100 I have to reduce it to 120, 80 right now. No. If you are doing that, you are actually going to harm the patient. So gradually reduce. Target some 10 to 20% reduction in BP over 24 hours. Not drastic reductions, not an ischemic stroke. Hemorrhagic is like another ball game. I'm not discussing that right now. So if thrombolysis is planned, again, BP cutoff is 185 by 110. After thrombolysis, you go for 185 by 105. Little bit different, but at least you keep this ballpark in mind if thrombolysis is planned. Generally, if you're going to control this, you have to give some IV medication. Don't try to control with this amlodipine. Amlodipine will take like 12 hours to act. So, which is amlodipine? I'll tell you a secret. Amlodipine is useless in emergency department. Never write amlodipine stat. If thrombolysis is not planned, you can go up to 220 by 120 and reduce by around 10 to 20% over 24 hours. Thrombolysis के लिए क्या दे सकते हैं? You can give altiplase doses 0.9 mg per kg. You don't have to buy heads. You can always refer. Maximum 90 mg. 10% will give it as a bolus. Rest is infusion over 1 hour. The newer drug that we have started giving in our center is altiplase. Your doses 0.5 mg per kg. You can give it as a bolus. Why? Because it generally has a longer half-life than altiplase. So the infusion part is actually not needed. Maximum you can give up to 25 milligrams. And it has some other advantage, like it is more fibrin specific than altiplase, and it has less likely to be affected by plasminogen activator inhibitor and all. So some kind of theoretical advantages, not so it is like an accept right now we do consider it to be an acceptable alternative as of now, although ideally we do need more evidence. Always remember the contraindication or this checklist. I'm not going through each and every one of them, but you have to go through the checklist before thrombolizing any kind of patient. Patient keep this in mind. Head injury within 3 months, ischemic stroke within 3 months, or any hemorrhagic stroke ever in the patient's lifetime. Any GI bleed within 21 days, no, you have to release thing multiple times before thrombolizing that kind of patient. If the patient is on a warfarin, the INR should be at least less than 1.7 if you're wanting to consider thrombolysis. And these things you can go through. So after thrombolysis, how do you manage? So BP cutoff, I already told you. You will not give any antiplatelets in the 24 hours after thrombolysis. Makes sense? No extra tubes, no NG tube, no Ryle tube, no unnecessary tube for the patient, because that will just lead to bleeding. So no. Vitals monitoring as per AHA, every 50 minutes for 2 hours, every 30 minutes for 6 hours, and every hour till 24 hours total. So first 2 hours, 15 minutes, then every 30 minutes for 6 hours, and then hourly till 24 hours. For even if you're not doing this exactly, at least keep in mind that such patient should to be monitored very, very closely for the first 24 hours. Going to anticoagulants in stroke, you can give aspirin or aspirin plus clopidogrel. This is going to be a little bit tricky. If you have a very, very high severe stroke, NIH is more than 5. Generally, you give only aspirin, because if you give dual antiplatelet, the risk of bleeding is very high. So like unacceptably a little bit too high. If it is a minor stroke, you can start both. This is difficult to understand because if you read TIA management, it is like ulta. So when it comes to ABCD2 score and TIA, but in stroke, severe stroke, only aspirin, minor stroke, aspirin clopidogrel. Anticoagulants basically only if you have a cardioembolic kind of stroke. Only then we will start thinking about anticoagulants purely for stroke. For words on TIA, then I will give it to Sahana. What is the definition of TIA? Sobiq, definition of TIA?
Hey, neurological deficit within That reverses within 24 hours. Any
I'm sorry.
neurological deficit there.
Any focal neurological deficit that was
That reverses within 24 hours.
reverses within 24 hours. This is what this is why I asked this question. This definition has been changed by around half a dozen or more times since this 24 hours first came. Do you really think a TIA will last 24 hours? No. So that was a definition when our faculty were residents. So that is not the definition used right now. They changed it to like, I think initially they changed it to like 1 hour, then they changed it to like 20 minutes. Now they have removed the time limit completely. They have transient neurological dysfunction can be affecting the brain, spinal cord, or retina. Important thing is no impact on imaging. No impact on imaging. And what imaging do you need? Diffusion weighted MRI. This is the latest definition of a TIA. No 24-hour, nothing like that. This is the latest thing about TIA. You need two things: transient symptoms plus no impact on imaging. This is the latest thing about TIA. This is what is actually TIA. If a TIA comes, the next thing you do is try to find out some important causes of TIA, like atrial fibrillation, any clot in the heart, endocarditis, something, or do a carotid Doppler, look for any cervical artery dissection. Usually it's related to some trauma, but trauma history might not always be available with you. Peritoneal foramen evaluation is something that is more for inpatient teams than in the ED. Do something called ABCD2 score. So you can go through the components later on. I'm not going into that for want of time. Basically, 0 to 3, 4 to 5, 5, 6 to 7, low, moderate, high risk of stroke at 90 days. So basically, what you're worried about with TIA is this patient likely to get a stroke very, very soon? You don't want to discharge the patient comes back after 2 hours with a full-blown stroke. So that is the thing we are worried about. So based on this, you can start patients on antiplatelets. Here it's like ulta of the patients with stroke. So if the ABCD score is high, that is more than 4, you start both aspirin and clopidogrel. If it's low, then you can give only aspirin. Think that patient is having any risk factor for cardioembolic stroke, you can start the patient on anticoagulants also. So this was in brief about management of TIA, and I am going to stop myself here. And localization of stroke, I'm not going into today. We can do that in another class. And I'll stop here for questions, and I'll as while Sahana will get ready with her presentation. So if anybody has any questions or they wanted me to repeat anything, you can ask. Hope this was a little bit. Sahana, I think you can share your screen now when you're ready. Now, I hope this was kind of clear, because stroke is a difficult topic to learn actually, because it's like constantly changing. The management protocols, the algorithms, everything is keeps on changing. I have simplified a lot of things with my presentation. Maybe some of the things were actually oversimplified. When you're going back and reading, maybe you'll find something that was a little bit more complicated than what I described. But I will try to make it as digestible as possible for the beginners. Now, Sahana, who is one of our best residents here in our ED, so I will give it to her to speak something about mechanical thrombectomy, especially in the 6 to 24-hour window, and what to do about those cases.
First of all, thank you, sir. And I guess I'm audible.
Yes, you're audible.
Audible, okay. So hi guys, I am Sahana. For all of you who don't know me, I think most of you guys know me. So in the next 20 minutes, we'll discuss something about mechanical thrombectomy. I'll just go through the history of mechanical thrombectomy. Why is it useful for us? And like a brief overview of mechanical thrombectomy. I hope I don't bore you guys. So as we have already discussed this thing, there are two types of major strokes. That is, one is a hemorrhagic stroke and the other one is an ischemic stroke. In this particular lecture, we'll be concentrating mostly on the, not mostly, only on the ischemic stroke, because we are talking about mechanical thrombectomy. So the name, as the name says, it is removing the thrombus from the vessel by using certain devices. So before knowing when to do it and how to do it, we should know in which all vessels we can do mechanical thrombectomy. First of all, why is it even important to do mechanical thrombectomy? Because we already know that we have thrombolysis, we have altiplase for this, but still we are talking about mechanical thrombectomy. So why is it useful for us? One thing is that there, as sir has already told us about the blood circulation of the brain. We know that there are certain vessels which are called as large vessels, like the internal carotid artery, proximal MCA, vertebral artery, and the basilar artery. So all these vessels, as the name suggests, they are very large vessels. So the large vessels, to become occluded, they require a large thrombus. So whenever there is a large thrombus, the use of this IV altiplase or other thrombolytic agents to completely remove this clot is very less. And almost about 40% of the ischemic strokes, they have large vessel occlusions. So in these cases, if we give the thrombolysis, the efficacy of the thrombolysis is less. So that led to this idea that we require something else, that is removal of the thrombus, which is called as mechanical thrombectomy. So all the studies that have been done till now, they have concentrated only on the large vessels, that is the internal carotid artery, proximal MCA, both these two vessels for a mechanical thrombectomy. So how this mechanical thrombectomy is being done is that, as there are different ways to do this. There are different generation of mechanical thrombectomy devices, which we are not concerned with right now. But however, there is one type, that is using a stent to remove the thrombus, because all the trials which we'll be talking about, that is DAWN and DEFUSE, they have used this particular kind of device for the clot retrieval, that is using a stent. How it works is that you pass a stent, you pass a device containing the stent through the femoral vessels. They reach the vessel that is occluded. Once they have reached it, initially the stent is in a closed format. Like as you can see in this image, the stent is very small. It has not opened up. As soon it takes some, then you have to insert this stent into this thrombus. Once it is inserted, the stent slowly opens up. So you have to wait for some time. Once the stent is opened, it completely opens up, causing the blood, it allows for the blood flow into this vessel, and it adheres to this clot. Once the stent is adhered to the clot, you retrieve the clot. This is how mechanical thrombectomy is done. So basically how it started was in 2013, there was one important trial which has happened, that is the IPS 3 trial, which showed that they have compared endovascular therapy with IV altiplase, and they said that endovascular therapy did not have any benefit and it is futile to do this procedure. So in 2013, they said that a mechanical thrombectomy is not indicated for stroke. Then what happened was there was a drastic change that has happened. In 2015, there were multiple trials like the MR clean trial, and there is an escape trial. There is a extend 1A trial, SWIFT prime trial, and EVASCAT trial. All these trials, what they have said, what they did was they have compared altiplase with endovascular intervention, that is mechanical thrombectomy, and all of these trials, they showed that it is a mechanical thrombectomy has shown to benefit for all the patients with stroke who are having large vessel occlusions, and they are presenting within less than 6 hours. So from coming to mechanical thrombectomy being not important, it has changed in 2015 that within if the patient presents within 6 hours and is having a large vessel occlusion, then they can benefit from mechanical thrombectomy. So based on this, in 2015, the AHA, they have changed their guidelines and they have made mechanical thrombectomy within 6 hours as class 1 recommendation. But however, we as a medical professionals, we are not usually happy with what we have. We always want to try something more. We always want to push the boundaries. We always want to extend our knowledge. And that's what a lot of people have done. And they have explored the area of umbra and penumbra, which Mehul sir has already discussed. That is ischemic core, that is umbra, and there is something called as penumbra. Like as you can see in this image, this is one of the major vessel, and it is being occluded by a thrombus. So whenever this vessel supplies, suppose you think this vessel is supplying all of this area. So whenever this vessel is occluded, there is some portion of the brain that is being supplied by this vessel, and it is not being supplied by any other vessel at all. So immediately this goes into this dies, this part of the brain dies because it is not being supplied by any other vessels. But however, around this area, there is some other area which is called as penumbra, which is being supplied by this vessel. And there are also some small collaterals which are supplying this penumbra area. So if this area, this part is not yet, it did not die yet, but the core has already died. So no matter what you do, you can't save the core. So we are not interested about the core. What we're interested is that this penumbra area, whenever the vessel has occluded, if you don't do anything, the major vessel is occluded. So even the penumbra will convert into the umbra, which we don't want. As you can see, this is a huge area. So what we're trying to do with the mechanical thrombectomy or any other thrombolysis is that we try to save this area which has not died yet. So in mechanical thrombectomy, once you remove the thrombus, there will be perfusion again happening to this penumbra area, and the brain tissue will survive. So this is the main concept behind the two major trials, that is DAWN and the DEFUSE trial. So the DAWN trial, which was published in 2018, the full form for DAWN is diffusion weighted imaging or CT perfusion assessment with clinical mismatch in the triage of wake-up and late presenting strokes undergoing neurointervention with TRIVO. TRIVO is nothing but the mechanical thrombectomy device that they have used in this trial. So this is an randomized control trial which has included 26 centers across USA, Canada, Europe, and Australia. This is an open label trial, and there were about 206 patients that were enrolled in this trial. 107 were in the intervention arm and 99 were in the control arm. And this used intention to treat analysis. So I hope you guys know what is intention to treat analysis. Maybe Adu can say it.
I don't know, man.
Okay, so this was discussed in our last journal club. What in intention to treat analysis, what happens is that if like in this, if once the person, like once the patient is randomized, they will always be analyzed at the end. Like in this case, how many people were randomized? 206 patients were randomized. So in the end, when they were analyzing, when they will analyze the results, all the 206 patients, no matter if they were if they like all they were there till the end of the study or not, they will be analyzed. The result will be analyzed. That is called as intention to treat analysis. Okay, so in this they have used intention to treat analysis. And what the major inclusion criteria they used in this is they've included all the patients above 18 years of age, and obviously they should have an acute ischemic stroke, and they have taken the patients who have failed alteplase or either alteplase is contraindicated in them, and the timeline that they have used is 6 to 24 hours. This is very important. In DAWN trial, they have used 6 to 24 hours as the cutoff. And there's one more thing. The whole outcome is based on one scale, that is a modified Rankin scale, which is nothing but a disability score. It ranges from 0 to 6, where 0 is patient is perfectly fine, where in 6 the patient is dead. In between, the patient has some amount of disability with the increasing disability from 0 to 6. So the baseline disability they have used is 0 or 1. And obviously they should have a large vessel occlusion, that is either ICA or M1 of the MCA. And then they have used one more inclusion criteria, one major important inclusion criteria, that is mismatch between severity of clinical deficit and infarct volume. Based on this, they have divided into three groups. One is group A, group B, and group C. In group A, they have included patients with age more than 80 with NIHSS score with more than 10 and infarct volume less than 21 ml. And in group B, the infarct volume is less than 31 ml with age less than 80 years. In group C, the age is less than 80 years with infarct volume of from 31 to 51. So the the maximum amount of infarct volume they have used is 51 ml in this study. Initially, when they were conducting this study, they planned to do a lot of subgroup analysis. So they have categorized and even while randomizing, they have stratified the they did a stratified randomization because they planned to do a lot of subgroup analysis. But however, they stopped this study very early because they were having a lot of good results and they wanted to publish it. So the maximum amount of infarct volume they had was 51 ml. So in the intervention, they use a mechanical thrombectomy with standard medical therapy, and in the control group, they only had standard medical therapy. So the primary outcomes were what they tried to do was, as I said, it is completely based on modified Rankin scale. But they did something else. To the modified Rankin scale, they have added some weights, which is called as utility weighted modified Rankin scale. That is nothing but based on all the clinical studies that are available, they have given certain weights to each point of the modified Rankin scale. Like if the MRS value is 0, they've given 10 weight of 10, and if it is 6 at weight of 0. So based on this, they have calculated this MRS at a 90 days interval. So what they have found out is that the utility weighted MRS for disability at 90 days, it was about 5.5. As 5.5 means it is on the lower side of the MRS value. So that means it is good number, right? So they found that in the interventional arm, it was 5.5, whereas it was 3.4 in the control arm. And they also found this functional independence at 90 days, it was 49% in the mechanical thrombectomy arm, which is like very much significant. And they had certain secondary outcomes which also favored the mechanical thrombectomy group, like the early therapeutic response, which they have measured by using NHS score. If the decrease is more than or equal to 10 points, then it was almost about 48% in the thrombectomy group, and vessel recanalization was about 77%, and the change from baseline infarct at 24 hours was about 1 ml. As you can see, all these values, they are favoring the mechanical thrombectomy group. So this trial, they have shown that if the person comes with a large vessel occlusion with infarct volume less than 51 ml, and the timeline between 6 to 24 hours, that is less than 24 hours, if they come, then they are likely to benefit from mechanical thrombectomy. Then comes the next trial, that is the DEFUSE 3 trial, which is the endovascular therapy following imaging evaluation for ischemic stroke. So even this trial was also published at the similar time, that is it was published in 2018. And just 2 to 3 months after the DAWN trial, the DEFUSE trial was published. This was a randomized control trial. It was also a multi-centered trial, but it was only done across USA, not like the DAWN trial, which was done all over the world. And this is an open label trial, and almost about 182 patients were included in this trial, and 92 were in the mechanical thrombectomy arm and 90 were in the control arm. And this also used intention to treat analysis. So the inclusion criteria they have used is that they have, instead of just taking 18, they have taken 18 to 90 years of age with NIHSS of more than or equal to 6. And the timeline they have used is less than 16 hours. So from 6 to 16 hours they present, they can be included in this study. And the baseline modified Rankin scale they have used is 0 to 2, whereas in the DAWN trial they have used 0 to 1. So they have taken much more disabled patients also in this. And the one thing that major thing that you're supposed to remember is that the likely salvageable ischemic brain tissue criteria which they have used, that is infarct volume of 70 ml and ischemic tissue to infarct volume ratio. That is nothing but that they have used is 1.8. That means nothing but the penumbra to umbra ratio that they have calculated, that is more than or equal to 1.8, and the absolute volume of potentially reversible ischemia, that is nothing but the penumbra if it is more than or equal to 15 ml. So if the infarct volume is less than 70 ml and the penumbra to umbra ratio more than or equal to 1.8, or the penumbra ml is more than or equal to 15 ml, they have included all these patients into this study. So the outcome they got was and the outcome was also once again based on a modified Rankin score, and that was done at 90 days. And they found that the median MRS was 3 in the interventional arm and compared to 4 in the control arm. The secondary outcomes they got was like the functional independence at 90 days was about 45%, which was significantly important, like very high in interventional arm. And the reperfusion was about more than reperfusion of more than 90% at 24 hours was about 79% in the interventional arm. So again, once again, this study was also showing that mechanical thrombectomy, if done within less than 16 hours in patients who are having large vessel occlusion with penumbra of less than or equal to penumbra of less than or more than or equal to 15 ml, then they benefit from mechanical thrombectomy. So once again, this study also they plan to do it for a longer time, but since the DAWN trial was published, they have ended their trial very early, and they also wanted to publish their study. So this was published just 2 months after the DAWN trial. And there are certain like this table here, like it shows differences between DEFUSE and the DAWN. Almost all of them were similar. Just in the time window, you can see that it is only till 16 hours, and in DAWN it is still 24 hours. And rest of the things it is same, but there is some mismatch definition which is different, which I've already discussed. So based on these both studies, since they both are agreeing that mechanical thrombectomy is better and it can be done from till up to 24 hours, there have been new AHA guidelines in 2018 suggesting that in patients with a large vessel occlusion, if they present from 6 to 16 hours, then mechanical thrombectomy can be done. This is class 1 recommendation. And if till 24 hours, it is class 2A recommendation. So based on these two, we got the cutoff, that 24 hours cutoff for mechanical thrombectomy, and all the people who are present in the trial should take a note of it and should not regret the patients if they're coming within 24 hours and not with like only 4.5 is not the cutoff. You always have to remember about mechanical thrombectomy also. The beauty of mechanical thrombectomy is that you can see it in this image that there is an MCA. This is a DSA image showing an MCA occlusion. There is no, as you can see that the dye is not passing through beyond this, but after thrombectomy you can see the vessel has completely opened up and the dye is passing completely. So this is how beautifully the mechanical thrombectomy works. And this is what happened till 2018. Then what happened was there were certain newer trials which they have been published in 2023. Two trials. One is the SELECT trial and the ANGEL aspect trial. As we have seen that in both DAWN and DEFUSE, they have restricted themselves like till 70 ml. Like in DAWN trial, it was only 51 ml of infarct volume and 70 ml in the DEFUSE trial. But whereas in this SELECT trial and ANGEL aspect trial, they have they tried to do something more. That is, they tried to increase the infarct volume to more than 70 ml and about 70 to 100 ml. That is, trying to do this mechanical thrombectomy for large ischemic strokes. And both of these trials, they found that it is very beneficial to do mechanical thrombectomy if even for the large ischemic strokes having more infarct volume, like more than 70 ml. So this is something that's a new thing. And there is something, there is another thing, there is a new trial that is ongoing, which is a ESCAPE MEVO trial, which says that like usually all these trials that have been done till now were only for the large vessel occlusion. But however, there are medium vessel occlusions. So like the efficacy of this endovascular treatment in medium vessel occlusion is not yet known. But this one trial that is ongoing, that is a ESCAPE MEVO trial, whose results are like they will be out in 2025. Maybe after this, our approach to mechanical thrombectomy or our knowledge about mechanical thrombectomy might be changed. So let's wait for it. So that is it about this Dawn and DEFUSE trials. So if you guys have any questions, you can ask.
So that was a great presentation, sir. And I think you explained a very difficult topic very nicely with all those images and all. So why I designed this lecture to have this extra focus on this Dawn and diffuse thing is one of the last slides that I showed you, no? Class 1A recommendation, which is like the highest, which is the highest recommendation possible for mechanical thrombectomy based on the criteria of these two trials. So you have to have some idea about them. So at least remember the names of these trials. Then try and if you're an academic resident, you'll have to learn the inclusion criteria and all at least by the end of your final year. But again, like as Anna said beautifully, newer trials are coming. The guidelines are keeping on evolving. A lot of research is going into stroke. So by that, if you're seeing this lecture maybe like 2-3 years in the future, maybe most of the things that we share is actually outdated. So that it can happen. So when I was studying stroke in MBBS, the only thing that I used to learn was about NCCT to rule out hemorrhage. So now things have evolved so much, and we are doing so many things with all this perfusion imaging and all, calculating the infarct volume, penumbra volume, penumbra to the core ratios, and so all of these things are a little bit complicated. But just you have to be aware of the advances that we are making in the field of stroke. So stroke is like things that we are seeing day in and day out. So I just wanted to give everyone as complete an overview of the management of stroke as possible in the time that we have taken. I'm sorry that I've overshot time a little bit, but I hope this lecture was useful, and you can always contact me anytime for any doubts or any mistakes that may have mentioned in this lecture.
Yes. Sir, there's one doubt. You have mentioned 1.7 cutoff INR for patients on warfarin if they're coming, like if you want to thrombolize them. So like to get the INR report, it takes time, no sir. So what should we do?
There are some sport INR machines available. I'm not sure whether they are counted as reliable in this, but it's like tricky. So you might want to ask your neurologist about what they think about this particular situation. So these are complex situation, and whenever you have complex situations, it's always a good idea to ask multiple people what to do. So get the neuro people also involved and see what they like to do. But anyway, you have to be extra careful if you are indeed thrombolizing that kind of patient, because they can have massive life-threatening bleed. A lot of things can go wrong in a patient on warfarin if you give thrombolytics.
Okay, sir. Thank you.
Okay, I think we'll stop the recording now.